So when do you re-image a patient? They go through 8 cycles, right? Or eight biweekly injections. When do you re-image?
So, I mean, depending on how the trial is written, generally it's going to be somewhere in the 8 to 12 week range. I think in general, we see that these drugs, in general, they don't quite work overnight. It takes some time to harness the immune system. And so depending on how a particular trial is written, it's going to be along the 8 to 12 week mark is when we would re-image.
All right. What's coming down the road? So Ignite 3, you guys were doing that. What's coming down the pathway with intratumoral oncolytics?
Yeah, that's a great question. I mean, another one that's being studied that we are also doing at Northwestern, RP2. So RP2 is being studied in uveal melanoma. So all of this focus that we just went over has been primarily cutaneous melanoma. Uveal melanoma is a very rare subtype of melanoma. It occurs in the eye. That's where it starts, in the iris, ciliary body, or the choroid. And it has a high propensity to go to the liver. Like 80 to 90% of these, when they do develop metastatic disease, it tends to go to the liver. So RP2 has the similar features of RP1 that we've discussed with an additional CTLA-4 engineered addition to it. And it's looking really promising in uveal melanoma. I think in general with oncolytic viruses, it's really shifting the paradigm a bit. In the past, intralesional didn't quite make too much sense for the vast majority of melanoma patients because they all come to us with visceral disease. Having a person just with cutaneous metastases or subcutaneous metastases is rare, right? And so we needed something for these patients with visceral disease. And, an intratumoral approach was really kind of unheard of. But now with this platform, it's really exciting. And even though melanoma is the poster child for immunotherapy in general, I mean, imagine the application of this type of an approach in other immunogenic cancers, such as lung cancer, kidney cancer, etc. So there's a lot of excitement.
15 years ago, it was melanoma. Immunotherapy was with melanoma, and then we talked about doing it in lung, and now we're in HCC. We're all over the place. So right. I imagine, and we'll probably see a much more rapid inclusion of other cancer types with something like this soon.
Agree. And, in hem-onc, Tyler, if I may, melanoma is often looked to kind of get a sense of what's coming down the pike, right? Because it's such an immunogenic disease. We're kind of in a unusual situation where we get to test and try these novel therapies, first and foremost many times. And then if it's successful, then it is, then evaluated in some of these other immunogenic histologies.
I do believe Replimune is getting studied in some other types of cancers, correct?
It is, but it's the furthest along in melanoma.
Perfect. Cool. Because I could see a potential application in HCC. I could see this, there's patients that have very aggressive disease and you could throw the kitchen sink at them. You can let Riad do the Y90. And, some people are just going to have progressive biology. And if you could do something to help kickstart and throw the kitchen sink at them, especially if it's well tolerated, it makes sense that might be, it's always worth a shot. What other kind of points would you guys have for someone picking this up? What kind of advice would you provide to interventional radiologists who would probably be the listenership or practices, oncology practices in general, or integrative interventional oncology practices in general? What kind of advice would you provide?
One thing I would say is cancer, advanced cancer management used to really be primarily under the purview of hem-onc. And now the exciting thing is that it is now truly multidisciplinary. I mean, these are advanced state patients where, in the past it was more like, oh, this is a hem-onc issue. Like we can't really do any local therapies to kind of help improve outcomes, but that's totally changed, right? So thinking of just hem-onc to treat cancer patients is archaic now. I mean, we really have to think with our colleagues, have multidisciplinary forums where we really, kind of can brainstorm and figure out when do we all get involved? What sequence should we be looking at these therapies? I mean, at the end of the day, I want to really expand the armamentarium for my patients, right? Just help them live longer. I may not be able to cure many of these patients, but what can I do to consistently, just constantly improve on their progression-free survival with each new agent. And so I think it's a really exciting time to be in oncology now, in all the fields, including hem-onc as well as IR. We get to kind of offer these really novel therapies to these patients with very advanced disease.
For me, Tyler, a couple of things come to mind. One is, just to close off the concept of the logistics. Just when you think about academic or community centers or private centers, you have to think about the prescription, the RP1 prescription, who is doing that, the formulary, where is that coming, where is that being dispensed from, right? So there are some practical issues that depending on whether you're an academic center, community center, smaller center, smaller private practice, oncology practices will have to figure out how to deal with the expense of the drugs, et cetera, right? So all of this stuff comes into play. There are some biohazard issues that occur that need to be further sort of elucidated as we create this protocol for Replimune. So there are some practical things. On a more human level, I would tell you this kind of program, it really is a partnership, but it is, for me, I like to think of it as a Batman and Robin, and I'm Robin in this one. I love being Robin in this one. That's part of the role, and it's part of when you get to work with Batman's like Sue. I think it just really broadens the scope of what IO does, to be honest with you. And again, it really is a call to arms that we have an opportunity to help these patients, a patient population we rarely address, frankly. We rarely address in IR, and so this really broadens what we do. And it's just a different way of interacting with our oncology colleagues, but all of us are part of the cancer center and this and that. And so this just adds to that armamentarium. And to Sue's point, this just adds to the toolbox for what we can provide for these patients. And it's really a pleasure and honor to do all that stuff for these people.
I love it. It's a simple procedure with a very meaningful impact is what I see.